Framingham is a suburb of Boston that is 20 miles west of Boston. And a study was begun there in the late 1940s to look at the determinants of who was going to get cardiovascular disease. It was funded by the National Heart Institute. Now it has other names. It's the National Heart, Lung, and Blood Institute. But the Heart Institute at that time, there was no prospective study. This was the first prospective study, and there were many others that came shortly afterward. I think the crux of Framingham is that it's always had National Heart Institute funding. It's very difficult, as you were hearing from the lollipop presentation by the previous speaker. They started with very little in the way of resources. They had energy, they had a population, and they had volunteers. This can be done anywhere where there is the right combination. Money is an excellent lubricant to keep the machine going, but you need a machine, and the lollipop investigators have created that, and it's just fabulous. So the outline of this is going to be to go into risk factors. I'm going to give you, I could have easily gone before. Many of the things that you heard in the lollipop presentation that we just saw started with a framework that was created with other population studies for cardiovascular and metabolic risk. But I'm going to introduce some other concepts, and I'm going to keep refreshing the ideas that were brought up by the earlier speaker. And I also, the time is ripe to do this sort of investigation at different levels and think about this. What could we do in our region? You're not necessarily going to focus on first cardiac events. You might focus on an ACS population. And you've already done that with things similar to the extension of the GRACE registry types of investigations. You may focus on somebody with people with heart failure, just people with diabetes, just people prior to developing diabetes. There are a lot of opportunities, and many of those of us all around the world would be glad to provide advice and counsel. You're ready to have an epidemic. You already can see it, but one of the best things is to collect data as you move forward. So this was the initial hypothesis of the Framingham Heart Study that was described many years ago. Age, men, hypertension, cholesterol, tobacco, alcohol. Look at that. He says alcohol increases CVD. I'm not sure I have a slide in here about alcohol, but that, in fact, goes almost the opposite. Increased alcohol increases other risks, but it does not increase CVD. Physical activity, obesity, diabetes, and population importance of rheumatic heart disease. In fact, that got discounted fairly early in the course of Framingham because there's so much penicillin use in the United States. And rheumatic heart disease really ceased to be an issue in the 1950s and 1960s, and there just aren't enough cases to talk about it. That is an example of something in the rest of the world is still an important issue. Subclinical mitral disease has not been uncovered, and rheumatic disease. These are still important in a lot of parts of the world. The study has 3 generations. Now, I left Framingham. I still do collaborations with colleagues there over the last 8 years, but I left about 7, 8 years ago. And right before I left the 3rd generation, we'd already launched that. Each one has approximately 5,000 people. And once you are enrolled in the study, you are encouraged to stay in forever. And it's on somewhat of a community basis. And the recruitment, interestingly, and I'll mention some of these little clues. I think many of us who've recruited studies been involved. We're always eager to share clues for how to get people into population studies and to retain them. Well, one of them is individuals were recruited on a household level. So if we're not going to go in there if there are 3 people in the household, let's say a mother, a father, and a child, we try to get all of them if they are in the right age range. Also, people are sent things like birthday cards to remind them that the heart study cares about your birthday. You're also more likely to read the mail at the time of your birthday and accept greetings. There are all sorts of little things that come out over time to remind you that you're a part of a study. This is the first paper that mentioned factors of risk for cardiovascular disease. This was before the multivariable analyses that were mentioned by the Lollipop team. You can now do it on a laptop computer in about 4 seconds with his size database. There were no regression analyses in 1961. Those really came a little bit later. They were first developed by Duncan Walker, developed by the National Cancer Institute and the National Institutes of Health. And the Cancer Institute investigators did not have enough events. And they called Bill Cannell and they said, we think we could apply this new method, logistic regression, to predict who's going to get heart disease in a place like your study. And they tried it out. And this was what was done, though, with just standard chi-square analyses before that. As you can see, the number of risk factors increases the risk, and these were really high risk factors. You can see high cholesterol, high blood pressure, and then there was smoking, other simple things. So this was the wording in Bill Cannell's paper. Combinations of the 3 factors under consideration, 3 risk factors, appear to augment further the risk of subsequent development of coronary heart disease. As additional longitudinal observations are made, it's hoped that additional risk factors will be determined. And we're still doing that. Here we are 50 years later. Okay. So this is an example of a paper that Robert Abbott and I wrote after the first American guidelines had come out around 1980s, mid-80s. We had just cholesterol screening. We did not have any other screening. Wasn't sure that everybody was measuring anything beyond total cholesterol. And the critical finding in this paper was for men, and the next panel will also be for women. Even at the lowest cholesterol, as shown here in yellow in the front, low cholesterol, those have lower risk than the green and the red and the blue behind, but the HDL levels also mediated the risks. So individuals with very low quartiles of HDL had very high risk. As you can see there, 12 to 36 milligrams per deciliter in that yellow group for a cholesterol less than 192 increases risk. Now, there are not tremendous numbers of people there, but it led to the idea of using both total and HDL. Often that was popularized in that era using a ratio, and now we tend to use the individual measurements. But same thing for women, as you can see. Then we got into all sorts of fights, wars, struggles. Which one counts? We still haven't totally resolved that. I think the first thing to say, whatever counts, is whatever you measure best. Because if you measure something else poorly, and you can game the system, so some new factor will count. So if you measure total cholesterol and HDL, it counts, they both count well. If you measure both LDL and HDL, well, LDL is good too. Is it worth the extra money to measure LDL? That's some of what's in this panel here. And you get into what are called equivalents. In other words, when we do the pharmacology arena does this a lot for trials. Do you have a superiority or do you have an equivalent model? And that's now happening in prediction science. And you got some of that in earlier presentations. You can use total cholesterol, you can use total and HDL, you can use LDL and HDL, or you can use non-HDL and LDL. Or if you like apolipoproteins, you can use ApoB and ApoA1. There are lots of ways to do it. And what's different for science may be a little bit different for what you do for care. For care, we try to keep the cost down and to keep it a simple message to patients. What about blood pressure? You know, blood pressure, we go around talking about patients and we tell them they have hypertension. In fact, almost all these variables are on a gradient, and that's one of the simple messages to come out of 50 years. Is if you can measure it and you have enough data points, And what really drives your ability to determine the importance of a factor in a population is the number of events, not the number of participants. If you have 1 million participants in 10 events, you really don't have enough talk. You know, you shouldn't have spent so much money measuring something in 1 million people. You would have done much better to have had a smaller number of people and more follow-up and more events. Especially powerful are incidents over time, new events. And but hypertension is something, we should talk about blood pressure with our patients. The higher it is, in general, the higher the risk. And each millimeter imparts an increased risk. Now, we don't talk much about meetings and smoking. This is a very old paper now. Bill Costelli wrote, and believe it or not, The Lancet, is he? And this was a very simple paper. We have efforts in the United States going around, especially in the 80s, about safe cigarettes. So the message in here is an indirect message, and you say, okay, no smoking, the yellow group, I want to be in that group. At least I say that. And lowest risk. But then regular and filter cigarettes are pretty much tied. So where did the safe cigarette message come from? It came from the cancer arena, not from the cardiovascular arena. So when we talk to our patients, we should be saying there are no safe cigarettes for heart disease. That's number one. Number two is if you're going to talk about population attributable risk, and I'm going to give you an example of that. You tell Mr. Jones or whoever you're going to see at any part of the world, why should I stop smoking? You should stop smoking so you won't get a heart attack. Well, what about lung cancer and emphysema? No, you heard me. You should stop smoking so you won't get a heart attack. What about I've already had a heart attack, it's too late? No, you should stop smoking so you won't get another heart attack. I don't have data on that here, but these are fairly simple messages, and we shouldn't get, and then, well, I stopped smoking now, how long before my risk really changes? 10 years, 20 years? 2 years. 2 years your risk starts to get down there. So it's not too late to stop. You should always say that message to patients. And we've had some really great leaders in America. From Mr. Fitt, Oglesby Paul was one of the most famous. And he would ask patients for their cigarettes. And I don't know if it worked, but he would tell you about it when he'd make these presentations. He says, give me your packet of cigarettes. And then he'd tear them all up and he'd throw them in the basket. So make a statement. And as physicians, part of it is to avoid smoking ourselves. You've seen this already about diabetes. It's just in here for completion, doubling and tripling of risk. And then we led to what is a risk algorithm. So let me give you a couple minutes on that. I was involved with the first risk algorithm in 1987. We published a paper, American Journal of Cardiology. We know the people who read the paper because it had an error in the equation, and they send us, we didn't have email, they send us a letter or a call. Say, really good people, they say, you have a mistake. He said, thanks for calling. Yes, you're right. There is a mistake in the appendix. We did make a mistake. We got one of the coefficients wrong. We corrected it. But then it led to a prediction paper in 1991, and then later paper I wrote in 1998, and then American guidelines in 2001 were based on pretty much the algorithm I'm going to talk to you about in the next few minutes. But this started out with people who didn't think you could predict heart disease. That was the whole point of logistic regression, which was a fixed time interval, and then later what's called proportional hazards or Cox regression, which allows different time follow-up. We can do this pretty well. And I'm going to go into a little bit of these elements of how you compare different studies in a minute. But you get a risk score, which is developed from the beta coefficients in these. And it's all the traditional variables. You're very familiar with those, and we've been talking about them. But how do you present the data to the patient? This is a very simple slide, and I often draw something like this, or if some of the computer programs will do it for your Excel programs, etc. So you have the numbers for the patient, and then you have two comparators. I give an example of two, because it's your local experts will determine what are the comparators. Then the first one for the starters is that where there's the 16% risk over 10 years in this man with these risk factor burden. Is this based on your data? Is this based on somebody else's equation? You better know, because it might not work in your population. For instance, should you use a Framingham risk equation in Indian Asians in London? We just saw that no, you shouldn't be doing that. Can you use a Framingham equation for the Europeans' background in London? Probably okay. You might not get the absolute risks right. And then you say, well, Dr. Wilson, why might you not get the risks right? I said, you're using this equation in 2013. That data was developed over 20 years ago. Well, that's the best we got. But before you apply it, you should start to test really whether it works. And we've made major efforts in that in the States, and the Europeans with the Euro score have made major efforts. So this is an ongoing dynamic process. But before, for instance, adopting a Euro score in Egypt or the GRACE score in Egypt or whatever, the REACH risk score, I've been involved with that for recurrent disease in your region, you should test it and get some advice on really whether it works accurately. And then I show low and lowest groups. For instance, that often depends upon how strong the program is in your country. Are you going to target a low risk group to get the patients to? That's your ideal, or the lowest. And part of that is money and resources for public health officials. Now, how do you tell whether you're doing a good job? And we have performance measures for risk estimation, and these are the three cardinal ones. I've written about these in some editorials in JAMA. You can find my papers on them. Don Lloyd-Jones as well, who's a colleague of Bob Bono's at Northwestern. But we start out with relative risk. And these are from the equations. This is important for the investigator, but not so important for the patient. The patient wants to know his absolute risk. Don't tell me have twice as much risk as the next person. I want to know if I'm going to really have an event. That's the absolute risk. But these other two elements, the discrimination and the calibration, I'm going to give examples for. That means, can I really predict well? And then the second one, which we saw from the lollipop study, it reminds you of high school science. Well, we have the same curve and the same gradient, but maybe we have different intercepts. So think of that as an intercept question a little bit, is calibration, okay? So here's what are called ROC curves, receiver operator characteristic curves, for regression analysis, yes, no. These are sorts of things that interventional cardiologists even benefit from seeing these, because you're getting papers right now that are talking about these types of metrics and whether you have a good way to predict an adverse outcome. So flipping a coin is a chance line, and 50% area underneath the diagonal, which is 50%. So you're always going to, if you read a paper, they're doing better than 50%. If they were very close to 50%, they couldn't get it published, even in a lower grade journal. So it's a question, how much are they going to get up to 1? 1.00 would be perfect. If it was perfect, let's say with 2 years of follow-up, that might mean it would be less perfect at 1 year or at 3 years of follow-up, or whatever different varying interval. So you're never going to see a 1. You're largely going to see numbers between 0.65 and 0.85, 0.9, and depends upon how the studies were done. So here's an example from the 1998 paper I wrote. This is using absolute continuous measures or categories, major categories. What's the scores, people say? Well, I said I felt embarrassed putting in this paper finger counting. That was finger counting scores on your, not bad, you'll say, okay? Because the ROC for that one is not too far different. But the ROC for the finger counting scores is about 0.65, and you typically get into the 0.7 to 0.80 for the other measures, and it's essentially a tie for categories or for continuous measures. So if you're talking about just a few millimeters of difference for a blood pressure for a patient and risk scoring, oh, come on, that just doesn't count that much. And you shouldn't rely too much on one or two measurements. We all know that. For many of these variables, more data and sort of the aggregate average is often a very reasonable approach. So here's an estimate of where the risk scores are for the 98 algorithm. This is going to change. There's a new algorithm that's going to come out in the American guidelines. It'll due to come out any month now. They'll go into a review process, but they ought to be finalized, hopefully sometime this calendar year. But most people, as you see, prior to age 55 or 60 are in the green zone, and then more and more get into the red zone. But an important message from this is a lot of the population, and that's much of the burden, is in the yellow and orange zone. The intermediate risk shoulders a lot of the burden across the population for where the events are coming from. So what do you think women look for? Next slide's women. A lot more green. Here we go. Look at all that green. So that's very good. Women just have generally a 10-year delay. And women, I don't have a slide in here, but women don't generally get a myocardial infarction as a first event. Historically, that's changed a little bit, of course, with PCI, et cetera. Historically, men would get about a little more than half of their events were myocardial infarction, 30% or so angina, 10% were sudden cardiac death. Women, what's the first event in women though? Chest discomfort, and it's not even classic angina. And I'm sorry I don't have a slide in there, but much more common presentation for angina or indeterminate chest discomfort. Myocardial infarction is about a third, and sudden cardiac death is really uncommon as a first event in women. Okay, so this is just an example of some of these types of genes. This is one highlight. I'm not going to go, it was a beautiful new GWAS types of description the lollipop investigators are doing. And Framingham's doing the same thing as part of very large consortiums. That's sort of the way that field is going. But like the epsilon 4 allele, the E4 allele is what we all know goes along with dementia, but also goes with lipid abnormalities and premature coronary disease. And it accounts, as you can see here, on a population basis, about 11% in Framingham. And that's been replicated across the ECTIM study in France and others. It's probably the most important genetic marker for cardiovascular disease. But these 5, 10, 15% and relative risks, as you can see here, 1.53 for ApoE4, those are what the genetic investigators are facing. It's not the diabetes types of risks where you have 4 or 5. That 4 or 5 for the diabetes, for instance, in the Asian studies, may be 4 or 5 markers, different markers for different families, and it'll be 1.3 times 1.5 times 1.4. That at each of those multiplying in that individual patient. That's sort of the way many of us think the world's going for that. But those gene variants may not be real common, as you saw in the minor allele frequency. They may have 20, 30% of the population. Occasionally, of course, you have very low frequencies of these minor alleles. So when we look at these uncommon things like familial hypercholesterolemia is important in Framingham. It's important everywhere it's been looked. But it's 1 in 500. We just can't do all of the next generation genetic research with that. Now I'm going to finish with lifetime risk. And this is a concept, this is, again, the Lancet. Boy, I'm realizing how much Framingham papers we've had in the Lancet. Don Lloyd-Jones got together with some statisticians in the Boston area. And this became his career. He's now associate professor, head of preventive medicine at Northwestern. And Don showed, for men it's pretty easy. I have come up with a simple algorithm. I call it the rule of 90-95. So if you take 40 plus 49, you come up with 89. 50 plus 47 is 97. So you can take a man's age and you subtract it from 95. That's his lifetime risk in Framingham. And I use that with patients. So if I see a 60-year-old patient tomorrow, okay, 60 from 95, you've got about a 35% risk. So if I use the 95, it says 43% here. But I'm at a very reasonable ballpark. And then I might calculate his 10-year risk using an algorithm, and his 10-year risk, let's say, is 11%. Well, which number am I going to talk about with Mr. Jones? His 43% lifetime risk moving forward, or his 10-year 11% risk? I talk about both. And I don't just talk about his being risk is twice that of his neighbor who's the same age. I talk about those two absolute risks. And we're going to hear more about that with new sets of guidelines as we're trying to use more lifetime risks as well. So that, and as you can see here, all the way across, women, the risks are lower. Now here's the same sort of thing as an example with diabetes and with obesity and with the number of years of follow-up. So if you get into 30 years of follow-up, which most studies just don't have, you can see here in the back right, for instance, the men, it's an 87% risk over 30 years for the man who, yes, has diabetes. That's the far right and in the back row there. Wow, that's overwhelming. That's just overwhelming. So versus the very much in the front is, and then obesity has an impact over and above the risk factors, the usual ones. Now, can you put that together? This is where lifetime risk becomes a little more problematic, is adding the risk factors. But as you can see here, we'll take that same person, my 60-year-old man I'm going to see in clinic next week. And so let's say he has two risk factors. We're at the left panel. He'd be in that top bar. He'd have that 45% risk. But he had all optimal factors, and that's what this paper was about by Don Lloyd-Jones, is he's down in the 5% risk. So these are the sorts of things, if you develop these on your regional basis, can really help you use your resources. And it's also helpful to motivate patients. You give them the feedback for their risk. Now, population attributable risk is another thing that you were hearing about in the Lollipop study, and it's a major goal for many of us is how do we assess this. So this is an analysis I did. It says in press. I apologize. It was published about 10 years ago. It's just an old slide. But it was looking at, do you need to be obese or can you be overweight to increase the risk for all these different outcomes? And the message in this slide for men is you don't need to be obese at all, and overweight is good enough or bad enough, depending upon your perspective, to increase your risk for almost all outcomes. You see there? And CVD death, but it doesn't account for as much as you'd like to think. So you see on the top, CVD death, 25–30% is accounted for by some element of excess adiposity. So the same sort of thing for women. Now women, they're just luckier. I don't know. Even with overweight or obesity, they don't have as much. And then some of them being a little bit heavy, it protects you. It goes in the opposite direction, the negative direction. We don't understand that. And if you start reading the literature about heart disease, our heavier patients, sometimes that's okay. And being the thinnest patients, there's nothing worse than being real thin and having heart failure. Those patients are cachectic, they're very sick, they're probably poorly nourished, and so we have mixed messages for how we communicate adiposity control to our patients. This is a simple one. Almost everybody who gets heart disease, this is with Phil Greenland, who's at Northwestern with Bob Bono and others. A paper now a decade ago is that across multiple studies, almost everybody, 80–90%, have some risk factors. So the idea, it's neat to go after new risk factors, and we all are doing that. But you usually have some of the traditional factors if you're getting an event. So. Lipids, this just explodes all the different lipids. I'm not going to go into that here, but Framingham has been part of all of those. I ran the laboratory when I was there. Every different lipid collaboration we really encouraged, and it was a lot of fun. Here's an example for LDL particle size, smaller, denser particles. Now this has moved a little bit more into LDL particle number, is highly associated. Whether it beats out total and HDL, that's marginal. I'd still stick with the total and HDL for care, but it's a great research interest. Same sort of thing. Now, remnant particles.
Your time is up.
My time is up. And then you've seen the metabolic syndrome. We'll just go through this. I'll end with this. So this is what is called etiologic fraction analysis. This is the sort of thing that lollipop investigators, Framingham and others will do is, why is obesity not a risk factor? It is for metabolic syndrome and it is for diabetes. But this one, and I just highlight this, we do these regression analyses. But if you have a very simple model here on the left, in model A, you see a body mass index of 1.28, then that drops down once you add all these other variables. So you can start to understand what's happening to the effect of body mass index. And you do what's called a proportionality of risk analysis, and you look at how those risk ratios changed. And this is why we have mixed messages to patients about obesity. Because about 60% of risk goes through obesity, but measure the other risk factors and intervene on the risk factors can potentially lower risk without changing obesity level. So that's my last slide, and I'll leave you with this is the biggest challenge. You just heard about this with lollipop. I would say this is the biggest challenge to the Middle East and to most of the world is where are we going with newer currents and the new epidemic. The new epidemic for sure is excess adiposity. Also, some of it's regional adiposity at the imaging level. Some of it is molecular at the laboratory level, and bench as well. But moving from the adiposity through the risk factors, we get diabetes, heart disease, and we get other outcomes. And it's also changing the way we go. So more and more, the burden in the future is going through diabetes first, or borderline diabetes. So the classic smoker, high cholesterol patient who's gonna really at risk have a heart attack or sudden death, the man, that is a fading environment. It's really faded fast in the last 20 years in the States. It's this new accessory pathway, I like to call it, is through diabetes and obesity. And it goes straight into heart failure without a myocardial infarction. And a lot of those patients also have ACS as well. So thanks very much.
You have time for a question or two?
Go ahead. Start talking, I think.
Anyway, Dr. Peter, since Framingham's studies, and owing to the many cardiovascular prevention programs and awareness program and guidelines, I think more and more people are now receiving statin, aspirin, blood pressure lowering drugs even at low threshold. So how this could be considered in risk assessment, whether if you have two guys with the same risk profile for primary prevention, for example, but this is receiving drugs and this is not. Is any risk score for that?
The question is, how do you incorporate use of medications? And the new American guidelines, which have not been released, are addressing this, but the short answer is it's not going to get a lot better, because a lot of those data that are developed are from earlier times, not 2013, 2010 data collections. But we have a little bit of answer for that for the patient, for sure, with heart disease. In the REACH study, which I was a part of, we published last year, and it showed that risk is highly associated with coming down with aspirin or antiplatelet in general, aspirin plus Plavix, and also for statin use. So the question I think to turn back to you is what I say to my patients. And I tell Mr. Jones, interestingly, what we found in REACH was the same what the cholesterol trialists found in the Lancet reports the last several years. You're taking the statin tomorrow to reduce your risk of a heart attack 22%. And I'm going to say that again when I talk about lipids tomorrow, and I think we will in the other lipid presentations at this meeting. And whether you're a man or woman, you're young, you're old, diabetic, non-diabetic, first event, second event, and even with lower cholesterol, you're taking it for about a 20 to 25% benefit. That's why you take the statin. Then he says, what about antiplatelet? I said, you're taking that for about a 10% favorable effect. He says, should I take both, or if I'm only going to take one, he's now bargaining with you, which one do I take first? I said, well, you know, like, I want you to do both, you know, me, or a poly pill, whatever. But I would take the statin first, because in the modern era, the statins are more potent and they seem to work. If you've got a disease mechanism for which statin's going to work, that's probably more potent. Now, we have a somewhat unanswered question for aspirin in the elderly after age 65. Big American NIH trial with Australia to address this, called the ASPREE, A-S-P-R-E-E trial. So antiplatelet in the elderly, outpatients, not ACS or stent patients, still unresolved. And then finally, hypertension. It's probably a 10 to 20% favorable effect. It's certainly not greater than the statin. And the real reason to take the hypertension is for the stroke. So.